So in general, a general consensus is usually that the older you get, the more you spend on healthcare. Now the problem is that's a little bit skewed because what's happened is that the money spent on healthcare has been steadily rising over time. So for pretty much all of us that are paying into healthcare, insurance, whatnot, as you get older, you notice that you're paying more and more. In reality, though, there's not a strong link between healthcare spending and age. And when we look at this, so this is the population over time, all people, the average spending, and then average spending of under 65 versus over. So, yes, older individuals have typically been spending more, but what you can see happening over time from under 65 to over, yes, originally, older individuals were spending more relative to younger, but since 1987, it's actually been going down, where the rate of increased spending for younger individuals has outpaced that of older. And so you can see that here. This is the age 65 and over, and then 65 or under 65. And so the 65 and over is actually, the ratio has been getting lower. So when we talk about medical care, the biggest thing that, or nursing homes at least, the biggest thing that we need to talk about is nursing homes, or Medicaid. So the nursing home market drastically changed when Medicare and Medicaid and other laws were passed. So originally, Medicare and Medicaid did not pay for most long-term care. It was assumed that these expenses were for families and that they were kind of on their own. However, what ended up happening was Medicaid was indirectly used for long-term care. And the reason why is that what happened was Medicaid is really a last resort type of payment kind of thing, and it's used in need. And what happens is long-term care patients fit in the category of being eligible to use Medicaid when they need the long-term care. Okay, and so when we look at this, this is the sources and uses of funds in nursing homes, and this is as of 2010, I believe. You can see that Medicaid is the largest portion of it. And if we look at, as of 2015, this is just nursing homes, Medicaid is about 32% of all spending in nursing homes. And then you have Medicare and out-of-pocket, 24 and 26%, and then other within there. And so, because of this, because basically what happens is, if you don't have money and you're on Medicaid, you can go into a nursing home, or the other circumstance is you go into a nursing home, when you go in there, if you have any kind of wealth, they start pulling money from that wealth, and that your wealth level goes down until you don't have any wealth left, and then you become eligible for Medicaid, and you can then stay in the nursing home. Okay. So that's why earlier when I talked about how low-income individuals were more likely than high-income individuals to be in nursing homes, this is why. You either go into a nursing home with Medicaid or on Medicaid, or you go in there not on it, but you become eligible as your wealth levels come down. Now, because of this safety net, Medicaid expenses within states soared out of control. It became a very, very big issue. And this is why Medicaid has actually become a growing portion of many states' budgets, over time. Now, something else that happened was because Medicaid was available, if you wanted to go into a nursing home, it basically became guaranteed that you could get in regardless of how much money you had, how much wealth you had. And so this created very, very high levels of demand. But there was a limited amount of supply. So you had a shortage of nursing home beds. And because of this, there's a lot of building of nursing homes, and again, this also led to the more spending of Medicaid, which hurt states. Now, states tried to either fought this by capping prices that they would pay per day, or by halting construction. So they would try to cut back on that. So then from a nursing homes perspective, the business perspective, they were looking at basically two groups of people to pull from. So they had the private market, people who could pay with either their own wealth or their own long-term care insurance or some other method, or from the Medicaid market. So if we look at this, it created a unique market. So with Medicaid, there's two different markets. You have the private pay and the Medicaid. And so the private pay is going to have that normal downward sloping demand curve. All right, the higher the lower the price, the higher the quantity demanded. On the other hand, you had the Medicaid, which was, there was some price that the government would agree to pay per day, and that's what they could get, up to the number of qualified. Okay. Now, if you pull up my marker here, all right. So the way that they would, the nursing home would go about their business of figuring out who to bring in, how much to charge. Well, when you look at it, and let me put in this line all the way across here. So the way that they would go about it was, all right, well, this is the price here that the Medicaid covered individuals would be able to pay, that they would be able to get from them, while the demand is what they were willing to pay over here. So what they would do is they would choose first from all these individuals up to this quantity right there, little q. Okay. Because for that group, they're willing to pay more from the demand curve, a nursing home room bed, than they would get from the Medicaid. So this amount here is that same Q. Now, this second group down here, they're not willing to pay as much as they would get from Medicaid. So, they could either charge these lower prices in here or start bringing in Medicaid patients and get the higher price. So then from this Q here to this amount here, because the Medicaid, they were willing to pay more, they're going to take that group here and then accept them here, and then they would take the rest. And so what we have here is we have this two-market nursing home system. So we have first the private, then Medicaid, and then the rest of the private. Now, what they would do then is they would charge more. They would really price discriminate with it, which is where they would charge different prices. So they would choose profit maximizing price levels for the private and for the Medicaid.